Thank you, Mr. Chairman. I would like to thank you, the Scientific Committee of the Congress, for inviting me for covering this very hot topic, how to engage immune response against MSS colorectal cancer for a second year in a row. These are my disclosures. This will be the learning objectives of the talk. Will be about understanding the immune biology of non-MSI colorectal cancer, review and discuss the results of the recently reported initiative to increase immunogenicity on this patient population, and know the rationale behind the different strategies under development to engage immune responses in this tumor type. So as a matter of introduction, we have different populations of colorectal cancer when it comes to the interplay with the immune system. This is the part of the hypermutant colorectal cancer, mainly MSI, that have been just covered in the prior talk. These tumors have higher number of mutations, more reactivity in terms of lymphocytes, and then they respond to anti-PD1 inhibitors and other immune checkpoint inhibitors. The present talk will be about this other population, the majority 95% MSS colorectal cancer, where the dogma says that these tumors have a lower number of mutations, then they don't have any immune reactivity, so they don't benefit from immune checkpoint inhibitors. However, if you take a deeper look on this phenomena, we see how this is not really true. So we see here all the tumor types clustered according to over a medium number of mutational tumor burden and the response rate presented with classical immune checkpoint inhibitors. And we see how clearly a proficient mismatch repair non-MSI colorectal cancer is an outlier that according its number of average mutations, we cluster with some tumor types that had approvals with immune checkpoint inhibitors. On the right figure, we see the same phenomena shown in another way. We see how the average number of mutations in this population doesn't account for more lymphocyte infiltration. So there's something in between the average mutational tumor burden and the immune reactivity for these tumors. And what is that? So what we know is that MSS colorectal cancer comes with a very, very severe immune suppressive phenotype. Enterocytes lie in between the immune front and the microbiota, so the enterocyte cell is very protected at a functional level against immune responses, and colorectal cancers conserve this protection. So if we go back to the late 80s, to the polypadenoma adenocarcinoma sequence reported by Vogelstein lab, we see how to develop a colon cancer, we need to pass through different stepwise process that started by the acquisition of Wnt mutation activations in the Wnt pathway. We know that Wnt pathway is a very, very immune suppressive when it's activated pathway. The second step is the activation of the cluster MAPK and PI3K, mainly through mutations in the KRAS, but we also see mutations in other proteins, overexpression of growth factors related with this pathway. And then we got as a certain step the inactivation inside the tumor cells of the TGF-Beta pathway. And why do the tumor need to inactivate TGF-Beta pathway inside the tumor cells? Because the TGF-Beta is a tumor suppressor pathway, and the tumor needs to get advantage of an increasing levels of TGF-Beta in the tumor microenvironment to get protected against the immune responses. So this is the third step. And finally, we have the inactivation of the p53 pathway, and there is a growing body of evidence relating these inactivations in this pathway with hyperprogression to immune therapy. So in the next slide, we see how Wnt pathway activation accounts for a severe immune resistance. Here we have in melanoma how a progressive increase in the Wnt pathway stated by increasing levels of beta-catenin accounts for a progressive decrease on CD8 infiltration. And we have the same data in localized colorectal cancer samples, when the more activated is the pathway towards the right, the less lymphocyte infiltration towards the lower part of the figure. And the explanation of this fact came from this figure up to here. So what we have demonstrated in paired biopsies of metastatic patients is that the more Wnt activity, the less dendritic cell infiltration in the tumor microenvironment. And this happens because Wnt activation downregulates the expression of CTLA-4, which is the main cytokine involved in the chemotaxis of antigen-presenting cells. And this is very important at the biological level, because the epithelia that depend on Wnt signaling are the strata of the epithelia that contains the stem cells of the epithelia. So this Wnt activation is a natural way to protect the stem cells against chronic inflammation situations, and the colon cancer gets use of it. The second step commented is the activation of the MAPK-PI3K pathway. So what we know, and you are familiarized with the rationale because it's the rationale that worked to build the COTESO, the IMBLAZE 370 trial. So the activation of the MAPK pathway accounts for the regulation of major histocompatibility complex and thus down presentation of antigens. If we block MEK, we were able to increase T-cell infiltration, T-cell activation and replication, and interferon gamma secretion. And also we have similar data from paired biopsies included in that trial, demonstrating the same phenomenon in patients. Finally, TGF-Beta overexpression in the tumor microenvironment cause epithelial to mesenchymal transition, aberrant angiogenesis, aberrant inflammation, but very importantly, immune escape. And here we see how the combination of TGF-Beta inhibitor with an anti-PD1 inhibitor can turn cold tumors into very hot tumors that behave as if they were MSI high in terms of immune infiltrates. And we saw the same data of synergies in combination of anti-PD1 with anti-TGF-Beta in bladder cancer with this external validity to these results. So the problem is that the first generation immune markers, the ones that we are using commonly in routine clinical practice, doesn't capture these different phenotypes and they don't serve to stratify patients to different therapeutic interventions. So what we need to shift to a second generation of immune biomarkers, basically gene signatures that can give us the readout of the microenvironment and the tumor at the same time, multiplex immunostaining that can talk us about the localization of the concrete cells inside the tumor microenvironment and also the functional stages of the cells, and multiplex flow cytometry that can give you parallel information on the quantity and changes over time in the different cells of the tumor microenvironment. So the strongest initiative to use these markers to stratify colon cancer came from the consensus molecular subtypes. You are very familiarized with this classification. Before going into the consensus molecular subtypes to allocate patients to different treatments of immunotherapy, I want to make a disclaimer, is that CMS was a classifier built only to describe the different molecular backgrounds of colorectal cancer. Experience shows us that this classification cannot directly be used to allocate patients to different treatment strategies. But for the purpose of this talk, I'm going to divide the different molecular backgrounds of colon cancer, and I'm going to propose different rational-based immunotherapy strategies. So going back to the consensus molecular subtypes, you know that there are 4 different subtypes. We have the CMS1. This group characterized, but they are tumors that behave as if they were MSI high at a functional level, but they are not only MSI high. Only 1/3 of these patients are MSI high, and the others are polymutant, BRCA mutant, BRCA-NES, ARID1 mutated tumors, and many others. We have the CMS2, which is the canonical group that depend on the Wnt pathway activation. So the majority molecular trait of this population is the Wnt pathway activation. We have the CMS3, which is the metabolic group, which is characterized by a metabolic reprogramming, and this metabolic reprogramming is pushed by the MAPK-PI3K pathway dysregulation, mainly through KRAS mutation. And finally, we have the CMS4, which is characterized by TGF-Beta activation and stromal proliferation. Since this is a gene signature, this signature can give us at the same time the readout of the tumor microenvironment, and we see how the CMS1 is a very hot and inflamed tumor with an anti-tumor Th1 lymphocyte-mediated response, with activation of T cells and overexpression of antigens through overexpression of major histocompatibility complex class 1. But on the other hand, the CMS2 Wnt-driven is a very cold tumor, as was expected considering the rationale of the Wnt activation, and CMS3 is also a very cold tumor considering that there is downregulation of major histocompatibility class 1 expression. And finally, CMS4 is a group characterized by a very aberrant inflammation, not constituting any kind of anti-tumoral immune response. So using CMS or the molecular background described by CMS to plan different rational-based strategies. For CMS1, perhaps you can explore the combination of anti-PD1 agents with anti-angiogenics, or perhaps with anti-CTLA-4 plus minus radiotherapy. We will talk a little bit more about this later on. For CMS2, here the rationale is blocking the Wnt pathway to allow dendritic cell infiltration and then foster T-cell reactivity. For that, it would be important to combine Wnt inhibitors with anti-PD1 agents. The problem is that right now, only 5% of the metastatic population had molecular alterations that are predictive to respond to current Wnt inhibitors. The rest of the mutations, which are APC mutations, are out of therapeutic reach nowadays. We need to wait for new compounds for that. In terms of CMS3, this group is characterized by a down expression of major histopathology complex. So for that, perhaps this is the right population to be treated with MEK inhibitor plus anti-PD1 combo. This is a minority subgroup and could explain why in the Coteso trial we did not see any relevant activity, but also natural killer engaging therapies, considering that these cells are the ones that kill the tumor cells that don't express major histopathology complex, could also be of use. And finally, for the CMS4, TGF-Beta together with anti-PD1 agents will make the difference in the near future in this subgroup. But besides this rational, biological-based therapeutic intervention, there is a bunch of other different therapeutic strategies that they are independent of the molecular background of the tumor. They are like independently active. Basically, it's the combination of immune checkpoint inhibitors with chemoradiotherapy, tyrosine kinase inhibitors, immune checkpoint inhibitor combos, metabolic disruptors plus immune checkpoint inhibitors, T-cell engaging bispecific antibodies, personalized cancer vaccines, and adoptive T-cell therapy. We're going to see the most important of it. I want to start with the most exciting story in colorectal cancer recently published. This is the data from the REGONIVO trial. This is a phase 1b/phase 2 trial conducted only in Japan in 2 centers, and this trial reported 33% response rate in non-selected MSS colorectal cancer. Rego was being given at 80 milligrams and Nivo was being given at 3 mg/kg. And if the most important is that you see the duration of the treatment, you see how the vast majority of treatments last for so long, so this depicts a kind of immune-driven effect. And most important is that at the dose selected for the phase 2, which is Rego 80 milligrams, the rate of grade 3, grade 4 adverse events was the half of the one reported with regorafenib single agent, that was 54%, and here is 26%. So why one treatment that provides 1% response rate in the metastatic setting and the other that provides another 1% of response rate in the metastatic setting? If we combine them, we got 33% response rate. So at the preclinical level, regorafenib targets CSF1. And we know, and this is data from regorafenib treatment models as well, that blocking CSF1 can differentiate back the tumor-associated macrophages, also called M2 macrophages, to the M1 phenotype. M2 macrophages are the most intense immune suppressive cells in the immune system, whereas M1 macrophages are amplifier of a Th1 directed immune response. So perhaps this could be the message and the biology behind this combination. But we have also data coming from paired biopsies performed in patients, and we see how the responders had a very interesting decrease on the infiltration of tumor of Tregs. And perhaps this elimination of Tregs together with the M2 depolarization could make the difference. And here is a very interesting case of a gastric cancer patient treated with Nivo that at the time of progression to Nivo get an increase on Tregs, and how the combination decreased the Tregs and accounts for responses. So which are the open questions after the REGONIVO data? So the first one, I think, is, can this impressive data be extrapolated to Western populations? There are trials ongoing in France, and there are trials ongoing in states that will answer this question. And the other is, why the elimination of tumor-associated macrophages and Tregs are so important for engaging immune response in metastatic colorectal cancer, where any single work at a preclinical level has described these cells as important in the cold tumors that metastatic colorectal cancers are. Another immune checkpoint inhibitor combination is this one reported initially at ASCO GI and then actualized at ASCO this year, is anti-CTLA-4 Anti-PD1. Before this combination, we got the data from the MSS cohort of the 142 EP-Nivo. For that cohort, the Nivo high dose, EP high dose, Nivo low dose reported overall survival of 10.5 months. However, the combination was never continued explored. This trial randomized patients to Durva, Treme versus best supportive care and reported a positive increase in overall survival of 6.6 months versus 4.1 months with a hazard ratio of 0.72. However, in the update in ASCO, the authors showed that this combination only increased overall survival significantly in the high TMB tumors, not in the TMB low tumors. The most important bottom line of this trial, because I think that the efficacy is quite modest if we weigh pros and cons together with the toxicity, is that 20% of the patients were high TMB. And this trial was calculating the TMB using the Garden test, so calculation on ctDNA at the time of the trial inclusion, which was at the time the patients become refractory to standard therapy. If we compare this super high percentage of high TMB with the TCGA data, perhaps we can conclude that during the course of the treatment, we are increasing the TMB of our patients because the changes on the percentage of both populations. So, as said, I think that the efficacy is quite modest considering the toxicity, and the PFS is quite short, so I don't think that this is a clear immune-mediated effect, but I think that perhaps we can demonstrate with this trial that we can increase the TMB during the course of the treatment. Another immune checkpoint inhibitor combination is monalizumab together with durvalumab. Monalizumab is a monoclonal antibody against NKG2A. Colorectal cancer overexpresses HLA-E, which is the ligand of NKG2A. NKG2A is expressed in cytotoxic lymphocytes and natural killers, and when it's activated, the action of these two antitumoral cells are blocked. So by using monalizumab, we can engage at the same time a natural killer response and a lymphocyte-mediated response. So based on that, a combinational trial combining monalizumab and durvalumab was presented last year in ASCO by Neil Segal and reported an interesting activity considering they were not selected population of 9% response rate, with a significant proportion of patients having an interesting PFS. But the most interesting of this combination is the low amount of toxicity. Less than 10% of patients underwent grade 3, grade 4 events. And this very favorable tolerability profile makes that it's possible to explore the triplet, and indeed it's currently being explored, cetuximab plus durvalumab plus monalizumab, trying to engage at the same time a T-cell mediated response and a natural killer mediated response. And this triplet is one of the most interesting things happening in the setting of MSS colorectal cancer. Another interesting initiative is the use of bispecific T-cell engaging monoclonal antibodies. Here you have one as a matter of example. This is an antibody specifically designed to engage an immune response on colorectal cancer because it's a CEA binding monoclonal antibody. So the way these drugs work is they bound directly at an antigen on the tumor membrane, and on the other hand, they activate directly the T-cell receptor without the need for antigen presentation to the lymphocyte. So it's a total made-up activation, but it's very promising in the field of the tumors that are called tumors. The problem with this drug is that since we are somehow creating like a CAR T cell when the antibody is binding to the lymphocyte, these drugs are somehow under the same problems that we have with CAR T cells. And probably at the end, we will need adopting the same safety measures that we are currently adopting for CAR T cells. We will see. And finally, for those patients not responding to the rest of options, we have the personalized immune strategies that could be personalized peptidic vaccines or adoptive T-cell therapy. But these strategies, which are very effective on patient-by-patient basis, need to be performed mandatory in centers with high experience because the process of developing these strategies is very, very complex. Basically, we need to calculate the neoepitopes of the tumor. You make the vaccine on one hand or select the lymphocyte clones reactive against this neoepitope and then re-infuse to the patient. So in conclusion, immunotherapy is not for all comers in MSS metastatic colorectal cancer, pending to see wider results of the REGONIVO combination. Deep understanding of tumor biology will be crucial to ensure their success and further implementation in clinical practice. A new generation of promising compounds and combinations, especially designed for this disease, are currently initiating clinical development. And finally, I would like to thank you, my mentor, Josep Tabernero, and my colleagues from the GI Malignancies Division at the Vall d'Hebron University Hospital, particularly Elena Elliott and Julia Martini, for all the support and daily inspiration. Thank you.